So we are live, hopefully. Okay. We'll wait until seven p.m. Anyone who is present, please leave something in the chat. This way we can have a more interactive course. Oh, hi Lucas. Pleased to see you again. So, are we all here? I'm good, Lucas. How are you? I'm looking to see if there are any new students. Okay, so if you do not have any new friends, then I think we should get going. I'll make sure that I spread the word. And we should get going. Oh, hi Karen, superbly. So we are more. That's good. That's extremely good. This means we'll have a more interactive course. Okay, so let's get going. We'll start with the first case. We have a 60-year-old male that presents to the emergency room confused. He was brought by his daughter. She found him on the floor of his living room, mumbling incoherently. The patient's history is remarkable for hypertension and diabetes mellitus type 2. His current medication includes metoprolol, captopril, and metformin. The labs show 1,240 mg per deciliter glycemia, a BUN of 40 mg per deciliter, a creatinine of 1.5, and sodium of 130. What is the best next step? We administer insulin. An IV normal saline is administered. A hypertonic saline is administered, or we perform dialysis. I'm waiting for your answers in the chat. So we have a C and a B, if I understand correctly, right? Okay, could you explain why you chose C or B? So we have actually A and B. Okay, why? Okay, Lucas is on the right path, but we have to consider the fact that he's a 60-year-old male and he has type 2 diabetes mellitus. As we can see, he's on metformin. This is the first line agent for diabetes mellitus type 2. It means he's not insulin dependent, so he's still able to make up some insulin. In consequence, there are no beta-hydroxybutyrate and acetoacetic acid produced. This diabetic ketoacidosis presentation is usually seen in patients with type 1 diabetes mellitus. In contrast, patients with type 2 diabetes mellitus have hyperosmolar hyperglycemic state. In the case of HHS, insulin is not useful as there are still a small amount of insulin made by the pancreas. However, the patients are dehydrated, so they require an IV normal saline. The correct answer is B. The best next step is administering IV saline, as the patient not only presents with hyperglycemia, but also with prerenal azotemia. His current confusion is caused by severe dehydration due to HHS. Insulin is not useful in HHS. Only the insulin-dependent patients, such as patients with diabetic ketoacidosis or with diabetes mellitus type 2 requiring insulin, may benefit from this treatment. Okay, so now we have a little bit of question on the renal system. We have three types of azotemia: prerenal azotemia, renal azotemia, and postrenal azotemia. Let us see. Can you give some examples of prerenal, renal, and postrenal azotemia? Okay, so yes, in this patient was prerenal because we had fluid loss due to hypovolemia. Karen, you're on the right path. So yes, indeed, heart failure for prerenal, hypertension also in prerenal. In prerenal causes, we also have hypovolemia, meaning that the patient can have hemorrhage. Postrenal, indeed, stones and BPH, and renal glomerulonephritis, acute interstitial nephritis, and acute tubular nephritis. Okay. Can you give me an example of congenital postrenal azotemia? Exactly, posterior referral valve. Yep. Great. Exactly, were superbly. Okay, so let's recap. There are three types of azotemia. The prerenal azotemia is caused by hypovolemia, which can be caused either by dehydration, as in the previous case, or hemorrhage. It can be caused by third spacing. In the case of liver failure, we have ascites, or by decreased perfusion, such as in congestive heart failure. Renal azotemia is caused by glomerulonephritis, acute tubular nephritis, acute interstitial nephritis, embolic disease, and rhabdomyolysis. In the case of postrenal azotemia, frequently we have obstructions, nephrolithiasis, BPH, congenital obstructions, or pelvic tumors. Let's double click a little bit on pelvic tumors. Can you tell me about a tumor that invades the ureters in females? Give me an example of pelvic tumors in females that obstruct the ureters. Okay, ovarian tumors. Do we have other answers? I don't know, did I lose the connection? It is me who lost the connection. Yes, cervical cancer. Yes, yep, but yes, sorry, this common cervical cancer is usually the one that invades into the ureters and is frequently tested on NBMEs. Okay, so the fractionary sodium is less than 1% in prerenal azotemia, is more than 2% in renal azotemia, and can vary between 1 to more than 2% if it is severe in postrenal azotemia. The BUN to creatinine ratio also will indicate what type of azotemia we have. A BUN to creatinine ratio of more than 20 to 1 is a prerenal azotemia. A BUN to creatinine ratio of less than 50 to 1 is indicative of, and it is variable in postrenal azotemia. For urine osmolarity, we have greater than 500 milliosmol per kilo in the case of prerenal azotemia. We have less than 350 milliosmoles per kilo in renal azotemia, and we have a variable value for postrenal azotemia. Has everything been clear? Can we go to the next clinical vignette? Do you have any questions on the topic? Okay. The next clinical vignette. A patient of 67 years comes obtuding to the ED. The medical history presents with hypertension, cough in the last 2 weeks, and feeling of weakness. On the physical exam, he has a dull area of percussion in the lower right thorax with egophony. Temperature is 39 degrees Celsius. The respiratory rate is 27 per minute. The systolic blood pressure is of 85 mm Hg. His labs show a BUN of 50. The chest radiography shows a lobar consolidation. It is decided that the patient is intubated and put on antibiotics. Despite improvement in the last 2 weeks, during the first week another area of dullness is observed on the left. What is the best treatment now? Ceftriaxone plus azithromycin, amoxicillin plus sulbactam, levofloxacin plus cefepime, or doxycycline? So we have a C, levofloxacin plus cefepime. Okay. Other answers, and also can you tell us why did you choose C, and also can you also expand on what means OCM, from what comes the acronym? So we have an A and a C. Yes, exactly. This is the trick, because in the question, the clinical presentation in the beginning is a community-associated pneumonia, but he's treated in the first phase, so it's a hospital-associated pneumonia, indeed. Now, can you tell me why he was hospitalized? Osmolality changes. So the fact is that you will have an extremely high osmolality in cases of hypovolemia, because you have less filtered water at the level of the glomerulus. This means that the urine osmolality is higher. In renal azotemia, it is the parenchyma of the kidney that is affected. Therefore, you do not have sodium reabsorption, solute reabsorption, nor water reabsorption. This leads actually to a decreased osmolar level. I hope I was clear. If not, I can re-explain. Indeed, he has actually a 5 out of 5. He is confused. He has uremia of 50 milligrams per deciliter. He has a respiratory rate greater than 20, a systolic blood pressure that is lower than 90, and he also is actually 67 years old. Okay, so let's see the answers. The answer is C. The patient developed a secondary pneumonia, classified as ventilation-acquired pneumonia. Therefore, the treatment must include a large-spectrum cephalosporin that covers Pseudomonas aeruginosa. This is represented in the answer by cephorpim. Until a blood culture is obtained, we either used aminoglycosides or quinolones additively to cover the antibiotic-resistant Pseudomonas strains. CURB65 is an index that we use to establish if we hospitalize a patient or not. The patient's score is of 5 out of 5. This is an indication for intubation, not only hospitalization. Scores of 2 to 3 indicate hospitalization. Scores of 4 to 5 indicate ICU admission. CURB65 is 1 point for each criteria. C comes from confusion, U from uremia, R from respiratory rate of greater than 20 per minute, B from systolic blood pressure of less than 90, and an age of more than 65 years. Okay, now let's recap a little bit what antibiotics do we give in pneumonia. So if we have an outpatient with community-acquired pneumonia that has less than 65 years and he had not received any antimicrobials in the last 3 months, we either use macrolides or fluoroquinolones. If we have an outpatient with community-acquired pneumonia of greater than 65 years with antimicrobials in the last 3 months or comorbidities, diabetes, COPD, we opt for a third generation cephalosporin, fluoroquinolone, and a macrolide. A community-acquired pneumonia requiring hospitalization goes with fluoroquinolones or antipneumococcus beta-lactam plus a macrolide. Pneumonia acquired at more than 48 hours from hospitalization or after intubation is treated with antipseudomonal cephalosporin plus aminoglycosides or quinolones until results of bacterial sensibility. If we suspect a MRSA in a critically ill patient, we administer vancomycin or linezolide. And now at the end, shout out to Karen, who actually pinpointed that there are more than 48 hours from his hospitalization. I think you can screenshot the slide. Do you have any questions? MRSA suspicion. Okay. We suspect MRSA in the case of patients that, for example, are in hospital inpatient unit and they were treated with an antipseudomonal and their state is still severely ill. For example, another clue for MRSA is the fact that we have abscesses associated with them, pulmonary abscesses. Was the MRSA suspicion clear, or should I expand more? Pleasure. Okay, let's get to the third vignette. A female of 32 years old presents with dysuria. She states that 2 weeks ago she made a urine analysis at the recommendation of her family physician. This one turned negative. The suprapubic pain that was present 2 months ago becomes especially prominent when she has intercourse with her partner. Although the physician prescribed NSAIDs previously, they do not calm the pain. The patient's history is remarkable for fibromyalgia. What is the best next treatment? Amitriptyline, corticosteroids, codeine, or ciprofloxacin? Okay, so we have an A. Could you explain why you chose A? Or D, actually. For fibromyalgia, okay. So let's resume a bit. This patient has a negative urinalysis. She has pain at the level of the bladder that becomes prominent with intercourse. They do not cease with NSAIDs. Also, she has fibromyalgia. This clinical presentation is typical for interstitial cystitis. As we know, interstitial cystitis is exclusion diagnosis. Therefore, the treatment is usually symptomatic, but if the patient is resistant, such in this case where NSAIDs do not work, we go for amitriptyline. Okay, I see your point. The idea is that she has a negative urine analysis. We can consider PID and cervicitis if there are, for example, if there is a discharge, if there is a positive urine analysis. Oh yes, and I forgot to say that on dipstick, if we have a UTI, we will have a positive leukocyte esterase as well as positive nitrates, and they will be mentioned in the question stem if they want us to suspect this. Was it clear why it was cystitis rather than UTI or cervicitis? Okay, so we have a no. So if the patient had UTI, we would she will present not only with dysuria, she will have a positive urine analysis. She would have leukocyte esterase and nitrates positive on the dipstick. In the case of cervicitis, she might have also discharge. Also, in the question stem, we would not have treatment of NSAIDs by the physician. He will never prescribe NSAIDs for a suspicion of UTI. He will prescribe instantly ciprofloxacin. On the other hand, this patient has only dysuria. She has pain with intercourse, and she has a psychiatric condition. She has a chronic pain condition. Namely fibromyalgia. This is why we suspect an interstitial cystitis rather than UTI. Okay, so indeed the answer is A, amitriptyline. The patient presents with chronic cystitis, painful bladder of more than 6 weeks with clear urine analysis. If the symptoms are refractory to the symptomatic treatment, such as NSAIDs, the next step in treating is TCAs such as amitriptyline. The mechanism of action through which chronic cystitis is treated is similar to diabetic neuropathic pain. A quick recap of interstitial cystitis. This is synonymous with chronic painful bladder. It is exacerbated by exercise, intercourse, or alcohol. It is associated with psychiatric conditions or chronic conditions such as fibromyalgia. The diagnosis is based on clinical findings. Urine analysis is negative and symptoms are present for more than 6 weeks. The treatment revolves around avoiding the aforementioned triggers. If the symptoms are refractory, we use amitriptyline. So, is everything clear? Should I expand more on the question? Great. Okay, so last question of the day. Buckle up. This is a pulmonology question. Let us see. So, a 65-year-old patient presents with hemoptysis at the emergency room. He's a smoker of more than 30 years with 2 packets per day. The patient has lost 50 kilos in the last 3 months. On the physical exam, the patient coughs frequently and takes deep breaths. The right arm has a BP of 140/80 and the left arm has a BP of 110/60. The chest X-ray shows an irregular nodule with speckled calcification towards the mediastinum. What is the poor prognosis factor seen in this patient? A. Speckled calcification on chest X-ray. B. Hemoptysis. C. The difference in blood pressure between the arms. Or D. Rapid weight loss. Could you explain why we have a speckled calcification as a poor prognosis? Lucas? D. Why rapid weight loss? Yes, yes, they're quite common. And why rapid weight loss is a poor prognosis factor? So we have an A. Okay, so let's take them one by one. So we start with A. Speckled calcification on chest X-ray is a differentiating diagnosis between benign or malignant nodule, pulmonary nodule. If we have a speckled calcification for a chest nodule, we will think that there is a malignant nodule. Hemoptysis is not a specific finding. Hemoptysis can be seen in TB, can be seen with pulmonary hypertension, therefore it's not even a factor of differentiating between cancer and other conditions of the lung. The last two discuss about rapid weight loss and the difference in blood pressure. Rapid weight loss is seen in advanced stages due to release of IL-6, a cytokine that leads to metabolic overdrive and losing weight. Now, the difference in blood pressure has to pinpoint our ears a little bit because the patient has no history of a congenital disease. The difference in BP here cannot be explained by a coarctation of the aorta, as it was a part of his history that would have been mentioned. However, on the chest X-ray, it is said that the patient has a nodule that invades the mediastinum. This means that there are rare cases when the tumor invades the aortic arch. In the moment we have invasion of a structure such as the aorta, but also it could be the recurrent laryngeal nerve, for example, and the patient could present with hoarseness, then it means that it's not surgically resectable. This is a sign of poor prognosis. So the correct answer is C. The difference in blood pressure with the chest X-ray showing a nodule invading the mediastinum is indicative of tumoral involvement of the aorta. Karen, Lucas, I know this question was a tricky one, but did you understand the reasoning behind it? Superbly. Let's review some of these poor prognosis signs in the case of lung cancers. The poor prognosis signs of lung cancer are hoarseness, this means involvement of the recurrent laryngeal nerve, fractures, metastasis to bones, or aortic murmur or differential blood pressure that leads to an indication for invasion of the aorta. Q&A time. Do you have any questions on pulmonology or nephrology that you had problems with during this week or when you prepared? Any specific murmurs? Could you expand a little bit, Karen, on any specific murmurs? Oh. Well, there are two types of murmurs that you can actually see. It could be a supravalvular aortic stenosis, meaning that you have the tumor that invades the aorta and this leads to stenosis, a false stenosis of the aorta. And the other one, if there is an involvement of the aortic wall that leads to loss of, let's say, not elasticity of the media of the aorta, that leads to dissection. And in this case, before dissection, there will be an enlargement and leads to aortic insufficiency via aortic regurgitation. Talking about this, do you know another example of supravalvular aortic stenosis, but that is a congenital one? No, you're quite there. It's not Turner syndromes, but Williams syndrome is the one that presents with supravalvular aortic stenosis. Turner syndrome presents with bicuspid valve, which will further lead to calcification of the valve and actual aortic stenosis, not supravalvular aortic stenosis. Okay, so I have like 3-4 questions for you at the end. Firstly, it would be great if you could leave me some feedback to understand how to improve the course. And if you'd like to recommend me to other students, recommend the courses actually to other students that might need a review on NBME type questions, that would be great. Another question would be, what type of NBME question related problems did you have in the last, let's say, 2-3 weeks, to know what would you be interested in approaching next time? Thanks for tweeting, Karen. Thanks. Lucas, thank you for the repost. Thank you very much. And thank you, Karen, also for retweeting me or tweeting me. I'm not familiar with Twitter, I think it's called. Gynecology. Oh, I know gynecology is such. I have actually made a APGO. I don't know what's APGO. For gynecology, Karen, there is a video. I made a video on the fetal heart rate, because there are a lot of questions in an NBME type questions where you are asked to differentiate between the treatment of late or variable decelerations, and they usually trick you, but they are easy points for if you understand in simple lines. Lucas, do you have any other problems? It's better to know. I know you've said about musculoskeletal the last time, and we kind of covered that, so I was wondering if you have any topics. And there are also two important questions. Firstly, I was wondering if you'd like to get a newsletter, like weekly or twice, like bi-weekly, with some free summary sheets on this type of questions. If you don't want to, I mean, I was thinking just that they might be useful to rapid review before an exam or before you go into the delivery room. Let's go with the OBGYN. Sorry, not this type of questions, a summary sheet on different topics such as fractures. I made a video on fractures and I posted a summary sheet on them. So I was thinking if you are interested or not to actually have a newsletter where I email you the summary sheet. But I do not know how could I get to send you an email. Maybe if you leave me a message with your email, maybe. Okay, and the last question is that I was thinking of making a series on basic EKG, a series of shorts, because I've seen that shorts are trending right now. So I was thinking that there are a lot of questions on EKG at step 2CK. So I was thinking if you will find it helpful or not. Lucas, or what? All the most basic tests. Could you give an example about what do you mean for all the most basic tests? I mean, I do not think that a short on CPC will be useful. Although, anyway, EKG TikToks, right? I do not have experience with that medium. Like a Coombs test. Okay, okay, now I understand from where you are coming. Okay, okay. Okay, I took note. Pernicious anemia, Coombs test, dehydro or Hoddermin test. Okay. Okay, so thanks a lot for the feedback and for being here, actually, for participating. I will go further and I will look into gynae and other topics that might be helpful for you. I will go further with the basic EKG shorts and other basic tests to make them. And I think that you could send me a message with your email on Reddit to be personal if you want the newsletter. And maybe this is how I could make the mailing list now in the beginning. And also, if you'd like to recommend me, it would be great. I mean, I'm saying this because at 1,000 subscribers or so, we can have a community, and this would enable the community tab to actually have a more interactive choice of discussion for these bi-weekly courses, meaning that I will ask you, okay, what's your interest, as in Reddit, but more focused on what actually we that we prepare for Step 2 CK need. With the Reddit, the problem is that there are always people that vote and do not participate, and I might make the mistake that I make courses for people that do not come, and maybe you that want to participate don't get the chance to have your topic explored and reviewed. So this is why I was talking about the community tab. Okay, Karen and Lucas, I'm grateful that you were here, and see you in 2 weeks. I hope, if you want to participate. Bye.